This test helps me make me a better doctor in a field where you've got such a crossover and overlap between our patients' clinical findings and their clinical symptoms.
Well, it's like a glaucoma patient who has some intertest variability on their visual field. You're not going to stop the therapy. You're not going to stop their drops. You can tell the patient, well, we're seeing a little fluctuation in the visual field, but what we're looking for is the trend over time. So the same thing with this test, and I take that one abnormal finding or the one where it doesn't get a little better, and I say, okay, well, this is a part of the overall picture. We're looking at the trend here, not just at this one isolated point in time.
And by the way, it also leads to non-compliance issues.
Yeah.
It's like glaucoma.
Right.
You
That's a good
put
point.
them on 2 drops, and the pressure's still the same. Like, oh, what's going on? Well, I missed it a couple days, blah, blah, blah. So, especially if you're using a corticosteroid, where you should see some improvement, I then say, well, are you taking the drops? Well, I took it for a couple of days, it felt much better, but I've stopped, and we've picked up a lot of non-compliance patients that way.
What do you do with a patient who comes in with a dry eye complaint and they get a 295?
Most patients have used 2 or 3 artificial tears. There's many surveys showing that before they come. Oh, I flossed before I went to the dentist. You have to give a therapy some time to work. So I don't see them back too soon. I'll start therapy. Here's the example. I'll start them on like a Lotamax gel steroid with cyclosporin, topically Restasis, and I make them wait 6 weeks. Then we see them back at 6 weeks, repeat the measurement, and you'll see improvement. You know, you're not curing the disease in 6 weeks. And if they see improvement, then they're going to want to continue their therapy. Patients are very satisfied knowing that they have something to follow with their osmolarity.
We all treat glaucoma. What's one of the main complaints that they'll all complain of? A red eye, right?
Red eye.
Red eye. And the first instinct is it's secondary to the drug. Well, the reason why I brought this up was the study that was in clinical ophthalmology last year, and it looked at patients who are on latanoprost, notorious for red eye. And at baseline, the average osmolarity was a little over 315, and they were switched to a preservative-free drop, and by week 6, they were down to just around 300.
A reason to maybe do a stent at the time of cataract surgery in these patients with knowing an elevated osmolarity with their symptoms. This would be another reason to get them off their glaucoma meds.
Osmolarity has almost become a vital sign in glaucoma care. A big part of our practice is glaucoma, and the ocular surface is a big vital sign, and numbers to support that help us take care of these patients.
Do you feel that the use of a glaucoma med is an indication to do osmolarity testing? Should we be screening people when we start them? Not screening, but should we be following their osmolarity when they're being treated?
Their surfaces are at risk, and it's very important for me going forward, just as I've used cyclosporin, just as I've used plugs in these patients, to offer this kind of testing. I would be looking in those patients, looking for
signs of dry eye,
signs of inflammation.
So what we can do is just have a higher index of suspicion in those patients who are on glaucoma therapy. So we just need to be more careful in asking the questions to these patients as they're on therapy over time about their comfort, looking at hyperemia, looking at corneal staining, and that's when we can initiate the testing for hyperosmolarity.
How are you gonna go long term now?
It's part of a post-op surgical regimen. It's different as I already have set visits I'm seeing them, but I'm talking about a non-surgical patient. I'll manage the therapy based on their next visit, and I always give the therapy a chance to work. So the osmolarity will actually have a better predictive value for determining what the next stage of therapy is.
The patient's tendency is to say, Doc, I'm feeling great, and they're going to want to stop everything. It's a chronic disease. We're not curing, we're controlling. You continue to follow them so that they can come in and get that number again.
It's allowed me to have a better gauge on what therapy the patient actually needs, since we know hyperosmolarity ties into the inflammation on the ocular surface. If that number's coming down, maybe I don't need the steroid, maybe just tears and Restasis. It's the final common pathway. No matter what the underlying cause, all of those patients are going to have high hyperosmolarity. I know I'm much more aggressive about asking questions about the ocular surface signs and symptoms to see if we need to do a TearLab to look at the osmolarity before having a patient go under the laser.
We actually use osmolarity in our LASIK evaluation. We want to maximize the outcome, and if they have an abnormal ocular surface or they have a risk factor for a condition that's 1 out of 10 patients that's relatively contraindicated to do the procedure, I mean, it's our responsibility as physicians to use these diagnostic tests we have now to make the procedure safer, and if it is indicated, give them a better outcome as a result.
Well, thanks, guys. I think this was really informative.